not sufficient. So first thing is like eyes. Okay, eyes is like the backbone of any case. Like whenever you enter into the room, from that there they start observing you until you leave the room. So opening and closing are as much as important, but where lies the backbone? You will start by introducing yourself. Sometimes you say good morning or good afternoon, and you don't introduce directly. Then the SP might be telling you good afternoon, and you have to then introduce yourself. So it's better to, as soon as you walk in the room, just tell that, hello, good afternoon. I am Dr. Musarat, and today is I'm GP in the clinic. How may I help you to? So as soon as you sit there, you saved your 10 seconds. And further, he will be proceeding with the presenting complaint, HOPI, and furthermore, past medical, drug, family history. Moreover, when it comes to the eyes, after psychosocial, many of our candidates forget it. Like someone think that idea is important and expectations are important. Sometimes some concern or expectation is asked, but all three of this together is very important. Like what the patient uh, has the knowledge about his condition. Very importantly, maybe he is so much anxious that it's a cancer and he cannot cope up with this. Okay. Secondly, is the concern. Maybe the patient wants to get admit. Maybe patient wants just a medication or just a lifestyle pattern. So our whole management plan will be depending on this concern. So if you forget and patient just wants the lifestyle for quite while, like optimizing their weight and changing their smoking alcohol habits, but you just starting them on directly smoking cessation therapies or on early stat or any weight reduction therapy. So the concern of the patient is not properly addressed. So here, these two things along with expectations. The concern could be, as I told you, that there could be cancer and he's concerned about his job, losing his job. If he's having TB positive, he might be concerned about losing his job and not telling to the employer. So we have to address everything. Along for that, expectations. If patient wants medication or lifestyle other than this. And after this, if you didn't ask ICE in the history, ask impact after this ICE. Okay. So this is the first thing we need to know about every patient. And next comes how you explain or how you ask the things. Sometimes you will say, "What's your problem?" And maybe the other candidate is asking, "How may I help you?" So there is a drastic change how you communicate with the patient. Even though both words are same, both meanings are same, but how you address the patient is markedly judged over there. So examiners want a calm, kind, and structure, especially also sitting posture, the way you have an eye contact with the patient. There will be notes and pens provided over there. But if you keep on writing everything on paper, this might affect your communication skill also. And whenever you go into the exam room, don't think that it's a kind of SP or it's a kind of exam. Think it's a real exam scenario. Sorry, real life scenario. So in that case, you will be thinking it's just a patient randomly came to my office, and how am I going to address him? So you can involve the patient, asking like I am going to ask you furthermore questions. Signposting is very important also, like I'm going to examine you, I'll be checking your vitals, let's move together to the management plan right now. And how does this sound to you? So you have to, communication goes both ways, not just from one way. If you go one way that I'm going to give you this, then it might just seem as a doctor center approach. So you have to involve the patient, like let him speak also, and avoid jargons. Communication also needs like clear-cut words. You cannot use you have irritable bowel syndrome and then you move on, or you just tell him that you have a pyelonephritis. Patient should know. If you are sending them to the urologist, he doesn't know who is urologist or who is nephrologist. So explain to the patient, each and every word should be in the layman language so they can understand. Okay, so next would be safety netting. Okay, safety netting. Our primary, as a primary physicians, our basic thing is to have a safety netting for the patient. You can you can be a GP that can make a mistake. It's okay. You can be a GP that doesn't know everything. It's okay. But if you don't tell the patient about the safety netting, like when to follow up, how to take the medication, and what things you need to keep an eye on, like blood in the vomiters or breathlessness or weight more than 2 kg in 3 days. So who is gonna tell that patient? So that's your primary care level. You have to prevent the things before it gets worse. So safety netting is one of the very important at the end of the every case. So it's kind of pass or fail bit because in for suppose in pyelonephritis or in pneumonia, you have to review the patient, or in PID, you have to review the patient in 48 hours. But if the patient is coming after 10 days, you know that's legal for the patient. So safety netting is very important. Along with that, sometimes we send the patient to the emergency department, and there our candidates lose safety netting point. No, we still have to tell, I'm sending you to the emergency department, and after coming from there, we are not leaving the patient just to the secondary care. We are telling him, as soon as you get discharged, please visit me. We have a lot to talk about. Okay, so and safety netting also, if you don't get time at the end, you can say if your symptoms gets worsen and you cannot cope up with your health at home, please visit as soon as possible. Okay. The next, what other things are checked, and what there are many feedbacks that unsuccessful candidates get is the red flags. So red flags, whole of the management depends on the red flag. If the patient is having vomitus with blood or weight loss or some kind of sudden vision loss. These are the red flags. We are not going to send the patient back home or giving this just a medication like a patient of anemia in his 40s with a change in frequency of his bowel movements. So in that case, you are not going to give the medication iron and send the patient back to home. Okay, so that's a red flag. You cannot ignore it, and you can only know that if you have a keen eye on the patient structure and history of the presenting complaint. Along with that, these red flags are very important for your management plan. So everything we are studying right now, like from eyes to communication skills, safety netting, and red flags, these are leading us to the management plan. Because whatever you are going to definitely manage the patient at the end of the scenario. Okay, and you have to tell the patient when you're sending him, like, I see this is something serious and we need to rule it out, and you cannot tell him clearly, like, you suspect that this could be a cancer, but you are not going to use the word cancer. Okay, until and unless you have confirmatory report in your hand about that cancer confirmation. Till then, you're just going to say, I am suspecting there could be a serious condition going on, but before I comment, I need to run some blood tests and I need a specialist input for that. And ask the patient, is that okay with you? Okay. So next is the shared decision making. That I just said that is that okay with you, or can you do this? And it's not just about the major plans, like not only for cancer, it's also for like even the little bit of the management plan. Sometimes patient is coming with IBS, or sometimes it's just lifestyle changes for his weight gain. So even in that case, we need to ask, can you just change your dietary habits, or is that possible if you can walk daily? Okay, because when the patient tells you that yes, they can, they make their mind, and there is that dedication that doctor is asking and I might be doing it, and they are agreeing on the plan. So it will make your commitment easier for the patient in real life, and in exam it's one of the very important thing they are saying. Okay. And sometimes there are things that in this shared decision making. You're not just giving the patient all the what you can say treatment plan, you're also giving them some kind of leaflets or some kind of action plans so that they can review it at home. Like for diabetes 1, if the mother is coming with concerns, you will provide her with the leaflets and with the handouts, like whatever it's provided from the primary care, to just let her read about the condition. Not in just this one case, there are many conditions. We provide home review, home like a leaflet for the patient. Okay, so next is referral urgency. Patient is coming to you, he cannot breathe, he's at rest breathless, for suppose, or he's been vomited since morning and he cannot take anything from mouth, or in acute pancreatitis case, you cannot return this patient to home because it will be life-threatening. So one of the safety corner of the primary care is you have to refer the patient, know that how urgent it is. Sometimes it's 6 weeks, sometimes it's 2 weeks, sometimes it's same day and admission. Okay, so you have to be very clear. Like 2 weeks referral is always for cancer suspected pathway, and even the little thing that if you ignore, for suppose unilateral obstruction or unilateral blockage of the nose more than 3 weeks, it's the red flag, and you are going to refer the patient within like urgency. You are not telling him to wait 6 weeks for a routine referral. You are going to send them with the cancer suspected pathway in the 2 weeks. So it's very important for you to see what referral urgency is for every patient and according to the guideline, definitely. And what guidelines are used? Till now, everybody knows like NICE is for everything, and then comes the WHO or local South Asian protocols for some infectious diseases. In fact, all of the infectious diseases, because infectious diseases, for suppose in malaria, is very much in high prevalence in Pakistan, but it's almost negative or not detected since 2016 in Sri Lanka. So it depends. The if they get even one case, they might treat it very differently. And here it's very regular, so we did treat it differently. So local guidelines management is mostly for your infectious diseases, and NICE is otherwise for complete chronic management or everything else, every other domain. And whenever you are telling about the guidelines, and sometimes you have a case for suppose about PCOS or about diabetes, you have to tell the patient so many things in that 10 minutes. Sometimes you can finish the case, sometimes you cannot. So what you can do in that way is you are telling the patient the major things right at the moment. For suppose if it's type 1 diabetes and you are telling them about injections and pens and insulin pens and dosages and how to keep that, and somehow you missed the sick day rule. You didn't tell them, somehow you didn't tell about hypoglycemic attacks, medical bracelets. So there are few things you have to tell, and there are few things if you cannot cover in those 10 minutes, you can verbalize them. Like I will be telling you, I'm giving you the leaflet regarding sick day rule, how to keep the insulin during travel days, and also about the medical bracelet is very important, and keep some candies in your pocket. And if there is something that we didn't discuss, I might be arranging another appointment for you because they know that you're not leaving the things, you're putting it in another appointment, but you know. Okay, so follow up and planning again very important. As we discussed earlier, safety netting and follow up goes hand in hand. And yeah, sometimes there are investigations that are pending, and we need to take it after days. Like I will be seeing you after we get your investigations. Okay, so since we done 25 cases yesterday, today is the 26th case, IBS counseling. Why is it written counseling? Because Uh, mostly IBS comes in a form of this stress-related condition. It's a stress guilt loop. and it's mostly related to the patient's stress level, anxiety. So that's why wherever the mental health is involved, the counseling will be the primary factor to address. And here also you have to check the patient differentiated from IBS and IBD. IBD usually has nighttime symptoms, like patient even waking up in the night to pass the stools, and that's not normal. But in the IBS, when the patient is at rest or asleep, their sympathetic is very much lessened, and they are in the relaxed mode. So that's how their stress doesn't affect their night, and it doesn't let them wake up for any bowel habits. So differentiating those both of things are very important. Secondly, screen for the red flags. Even though it's normal condition, we need to know, uh, does the patient has weight loss, any bleeding, or nocturnal symptoms, as I told you, any anemia, and every kind of bowel disease. Ask for the family cancer history. You can ask there is the bowel problems in your family or any serious condition. Try to avoid cancer word, but if you say if there is someone going through a serious condition of bowel in your family, then explain, and explain is very explanation for every disease is important. So next, yeah, management again it starts from lifestyle and diet. The patient should take regular meals, fluids, reduce caffeine and alcohol, along with the FODMAP style advice. Okay, FODMAP diet should be used. And sometimes you cannot explain to the patient about diet, so you're going to give the leaflet. Symptomatic treatment, everybody knows, like antispasmodics or laxative or antidiarrheals. If the patient has different pattern of stools, like sometimes constipated, sometimes diarrhea. And psychological is again important in the counseling cases. Tell the safety net, and tell if there is any red flag. You can say if you feel any severe weight loss or severe tummy pain, please present to us as soon as possible. Next, change in the bowel habits or the colorectal cancer. Suspicion is basically sometimes patient is not coming to you and telling you, doctor, I have cancer. Sometimes they are just having a regular follow-up of high blood pressures to you, and then maybe kind of different abdominal cramping, and you're asking the patient if there is more than 40 years old and patient is having different frequency of his bowels, we will always run CBC to check out if there is any suspicion of CRC. Okay, and important factor is 2 to 3 questions like, do they feel incomplete evacuation? Do they feel urgency? These two important questions should be asked in CRC screening. Secondly, the duration of any kind of change and the associated features. Like if the patient is getting change in frequency, he getting mucus, abdominal pain, any tenesmus, and also systemic symptoms where we check like weight loss, fatigue, and everything else. Okay, risk factors is family history. There could be previous polyps or cancer, or even IBD can change into the CRC. So we need to know the bowel habits of the patient. And lifestyle, again, smoking, alcohol, and how was the patient, BMI, everything is considerable in GI cases. Examination is again, you will go from GPE to abdominal to check any mass or organomegaly. Sometimes when there is lower GI involved, you will do detailed examination from the superficial to deep palpation, liver, spleen, the urinary bladders, your kidneys. But if there is written focus examination, then the organs will be specific, like liver, spleen, and then you can also do DRE. DRE for lower GI is very important. Red flags, persistent change in the bowel habits, or they get any looser stools, and mostly rectal bleeding in any older adult. It's a red flag, along with any mass on the abdominal or rectal examination. Management, if there is a red flag, they will be going urgently, like 2 week referral. Meanwhile, in that 2 week, you're not just telling the patient you're going for 2 week referral to the specialist. In that 2 week, you have to do something. Either this is diarrhea, blood in diarrhea, you are going to give them antidiarrheals. If there is cramping pain, you are going to give them antispasmodic. And if they are getting, for suppose in menopause, sorry, menorrhagia, if they are getting heavier bleeding and you are suspecting something suspicious, so still you have to control the bleeding till they reach to the specialist for in 2 weeks, like for suppose tranexamic acid. Otherwise, you have to be very honest in this case. How you cannot tell the patient, no, don't worry. Don't use this word in any cancer suspicious case. If you use it, because definitely he's going to worry later on. It's not a don't worry thing. So we are going to say that what I am getting on the examination on the history, it doesn't look normal to me, and I'm concerned about it. That's why I'm sending you to the specialist. It could be something serious, but I cannot comment until I get your reports. And he will ask what will happen to me to the specialist. Tell him in detail. They might be doing camera testing from down below, and they might be checking your like intestines or bowels, you can say, and they will let you know. And I will be keeping a close eye on you and having a follow up after you get there, get from there. Okay. There might be other questions from the SP, but basically they want you to check. You know the 2 week rule for the any cancer, and you send the patient right away with the red flags. And secondly, you keep a follow up. So these three things are very important, and don't say it's a cancer until it's proven. Next. So gallstone and biliary colic, one of the very common cases in your normal life, along with the examination point of view. Everybody knows right upper quadrant pain with some discomfort on radiating to the back or the shoulder, and patient is mostly telling you after meals. Okay, there are two things. If you're getting left quadrant pain after meals, that's ulcer. And if you're getting right quadrant pain after meals, it's gallstones. Mostly, what kind of meal you took? Mostly any fatty food, okay? Any junk food, fried food mostly. It will be coming with nausea, vomiting, and bloating. Screen for the complications. For suppose any systemic features, fever, rigors, patient is getting jaundice, urine and stool habits are different, and there's severe pain that is not going away. Okay, biliary colic is somehow less pain. It comes and goes after the meals, but gallstones is basically detected on when you have severe pain and on the ultrasound. Risk factor, definitely female with age 40 plus and obesity, and there could be rapid weight loss. And sometimes this case comes with the pregnancy, so that you are not going to handle. You are going to refer the patient to the a specialist at the emergency referral. And otherwise, examination for GPE, right upper quadrant, every disease has a particular focus examination. So in this case, forget everything except from GPE and the Murphy sign. Okay, if you don't do Murphy sign, that will be a pitfall. Management of uncomplicated will be normal, like confirm that the biliary colic is because of gallstones, or if there it needs to be an uh, elective operation, or you just have to control the pain and lifestyle changes because they need to have low fat diet, weight management, etc. And when to escalate is when it's acute cholecystitis, pancreatitis, or cholangitis, like severe pain not going with the fever or any systemic symptoms, then you're definitely going to admit the patient. They might need elective cholecystectomy. Counseling is again important if you're sending back to the patient, and follow up after they get back from the hospital. Next. Okay, so jaundice, go again, this is a GI topic. Focus history. Patient is coming with the itchiness maybe all over the body, or changes in the skin color, and sometimes it's just dark and pale, dark urine and pale stone with the tummy pain, fever, I guess there could be some of it. Jaundice, there are some risk factors in the psychosocial, like alcohol. It could be viral hepatitis. So don't forget, even there is no fever or no other thing, you still have to do the viral markers. As for the travel, IV drugs, the sexual history, and the transfusion, specifically in any kind of these cases. Medications, sometimes people are taking different kind of herbals, and it might overload the GI or liver, and might be taking some gym supplements, so it can also affect the liver. And sometimes the medication like the antifungals also can derange the liver function, so we need to be very specific about any regular medication or supplements if the patient is taking. Differentials could be pre-hepatic, hepatic, and post-hepatic. It will be more physiological cause if you go deep down. But just know, like there are few things um, that proceed to the viral and that proceed to the some anatomical changes in the jaundice workup. Examination will be jaundice scratch marks. Why? Because pruritus and weight loss important. And sometimes you get spider nevi, and also patient is also complaining of gynecomastia, or there could be ascites. So complete abdominal examination is important in this case. Initially, you will be running each and everything: CBC, urine electrolytes, LFTs, and the coagulation profile, bleeding profile, and urgent abdominal ultrasound, mostly to check if it's obstructive or if there is any other cause. Management is definitely for urgent same-day referral. It's obstructive jaundice, or even if in pregnancy there is severe pain or acute liver failure. Okay, and communicate the patient. If, for suppose, the jaundice is because of viral hepatitis, you are going to treat the patient symptomatically along with hepatitis B and C regimes if they need it, if there is positive test results. Okay, safety netting, and that's all for this. Comes the next constipation case. Sometimes patient just come, they cannot pass stools regularly. Okay, there could be psychosocial cause, maybe stress, could be dietary habits, it could be thyroid problems like hypothyroidism or things like this. So we have to rule where or it could be low fluid intake, occupational. Okay, there can be 3 to 4 things that coming. Patient is telling you stool pattern, they have to strain a lot. Might be some anal fissure after side by side with the constipation. So don't have to treat just the anal fissure. Try to treat both of the things. So can come into any context. You need to ask about pain. Lower GI questions will be pain, bloating, nausea, overflow, diarrhea, or sometimes weight loss and rectal bleeding. Okay, because constipation and diarrhea can be one of the differentials of IBD. Fluid intake, diet, physical activity, especially the occupation, and also if they are cold or heat intolerant, or hypothyroidism can be one of the cause in this case. Red flags is again weight loss, bleeding, corrective bleeding, anemia, and any mass. Symptoms are mostly colic abdominal pain, distension, vomiting, and failure to pass a stool. So this is the constipation case, and how we manage it basically. Firstly, you have to examine the patient. If there is written examination outside, you are going to do. If it's gray, try to at least check the superficial tenderness and how much distended the abdomen is. Okay. Manage the patient with the red flags, or urgent hospital admission if needed, or if it's cancer suspected, then 2 weeks referral. If there is no red flags like a psychosocial or fluid intake or medication, then you have to stop that. Now comes the gynecological cases, abnormal vaginal bleeding. This is Sometimes premenopausal, sometimes postmenopausal. For postmenopausal, everybody knows it's a cancer suspected pathway. After 12 months of complete amenorrhea, if the patient is telling you I'm getting spotting or heavy bleeding, refer her within 2 weeks. Meanwhile, give her the medication, the transamic acid, and ask about the anemia symptoms. We need to know how much breathless is the patient. Maybe it has already caused her systemic features, but it could be premenopausal like HMB, intermenstrual bleeding, PCB, or irregular cycles. In this case, the focus history is the important thing. Like you cannot just ask abnormal. How abnormal is it? How many times? How many days in a month? And every month does she get it? Or how does it impact on the life? Okay. And there are some few things like if this is IMB or PCB, basically it's a red flag, then we have to check for another anatomical causes, or we might need a specialist input on this. Associated symptoms, basically pain, pressure symptoms, and also some discharge along with anemia and fatigue and shortness of breath, you can say. Sometimes abnormal vaginal bleeding is not as such abnormal because a patient is taking COCPs. She just started like 2 weeks ago and she's coming complaining to you about I'm getting heavy bleeding. You need to know if it's contraception. So it's normal till 3 months. Okay, so you can also counsel the patient to every contraception you are going that can cause bleeding in the first 3 months. Tell them that it might cause you abnormal bleeding, and but you don't have to be very worried about that because it will get better after 3 months. Vice versa, if someone is coming after taking contraception with more than 3 months of abnormal bleeding, that you have to investigate that. Okay, risk factors is again obesity, age, PCOS, if they are taking any kind of tamoxifen or HRT, and postmenopausal is endometrial cancer. Yeah, family history of endometrial and colon cancer. Red flags, eh, postmenopausal is red flag, intermenstrual and postcoital, along with the abnormal examination on the abdomen. Examination is GPE and all the pelvic examination, including the abdominal. And whenever there is a gynae case, try to say because it's not examination, not you be doing on the SP. If you are verbalizing it, then it will be speculum and bimanual examination. You need to say these two words over there. Okay, and manage the patient accordingly. Sometimes patient is of PCOS and they started contraception and they got some abnormal 3 months bleeding and now they are uh, trying to get their fertility like clomiphene, etc. So in that case, there might be hidden agenda, like patient is uh, amenorrheic for 3 to 4 weeks. So in every kind of patient that's amenorrheic for 3 to 4 weeks, you are going to do pregnancy test. Even if the patient is telling you, no, doctor, it could not be possible, you still have to do. And also the initial baselines, and accordingly, you will start the management plan if the patient is wanting some contraception, if patient wants some fertility advice, or if it PCOS or HMB, okay, accordingly. Counseling and safety netting comes all along. Tell the patient if it's not something bad, you can tell it's a normal thing, it can resolve in 3 months, or I'm going to give you medication for it, or if it's if it's postmenopausal, then don't not to worry. Okay, next. Menopause counseling. Again, menopause counseling, the symptoms can be very much mimicking to the menopause and also depression because in sometimes patient is coming with low moods. Okay. So any patient who's menopause, screen for hypothyroid, screen for anemia, screen for menopausal symptoms itself. Okay. And you can ask like she will tell you I have and depression also. She has low moods, and side by side ask since when, and anemic symptom, does she get fatigue or breathless? Okay. Third is does she feel cold intolerant? Okay, hypothyroid. And also does she feel a lot of sweating? Yes. So that's menopausal symptom. There's sometimes perimenopause and sometimes menopause. So focus history, vasomotor, hot flushes, night sweats, sleep disturbance, mood changes. In fact, the intimacy is a loss between the partners, and also joint pains, sometimes cognitive issues are there. Menstrual history will be like normal and sometimes abnormal, like after weeks or after months coming. This is normal near the menopause. Risk factor could be breast cancer, VT in the family history, and very importantly, osteoporosis risk. So always check for vitamin D, calcium when the patient is coming with the menopause, and if it's needed, we can start them on the supplements. Past medical history is again migraine with aura and all these. Um, okay, next. Sometimes patient is asking for HRT, okay, replacement therapy. You won't put every patient directly on HRT who is going through menopausal symptoms. There are some low moods you're going to start SSRIs or SNRIs. If there is intimacy problems, then the lubricants can be provided, estrogen creams. And along with that, for bone protection and for everything else, if other things are not working, then you can refer the patient for the HRT. Okay, but there are risk and benefits. So if the station is regarding HRT, they want HRT, you need to know what are the risks and benefits both of the HRT. You are going to explain it to the patient. So if there is VTE, breast cancer risk, then definitely there are different regime, tamoxifen and some others. Um, that has detailed plan, you can read about it. And types can be estrogen only versus combined, and also some people need for progesterone. Also, must know that HRT doesn't protect as a contraceptive. So if the patient is telling you, I'm taking this medication, and also I'm not taking any other uh, contraception, and she's sexually active, then definitely you are going to give extra contraception method for that. And yes, HRT, it depends on your own local pathway. If somewhere the GPs are starting, but it's better to say after getting the specialist input. You're not going to refer the patient, but you might be getting the specialist input on call. Okay, so be on safe side. Tell them that after getting the specialist input, I will be starting you on the hormonal replacement therapy, or I might refer you for if you are perfect candidate for it. Non-hormonal, again, weight, exercise, and if it's sweating, and try to tell the patient to wear loose clothes, have a good AC room, try to sit in AC rooms, have good foods, weight loss, walk if she's having this depressed mood, etc. Plan this, plan and safety netting, and again, if HRTs is started, follow-up is needed. Okay, next.
Okay, doctor, I'll be taking over now. You look tired now.
Okay,
I'll be taking now. Thank you.
thank you, doctor.
So, doctor, that's about something. Now, doctor, let me add on one more thing. In obs and gynae cases, mostly the examination will not be required. It will be a counseling cases. Okay. So when there is a written no examination required, please don't touch the examination. For example, if like say it is mentioned examination, other thing I mentioned about examination. So please proceed with the examination. It will give you extra marks. Okay. In the vaginal discharge, doctor, most of the time patient will be shy and they will not be opening up. So you have to take the proper confidence and build proper rapport, then patient will open up. Most of the time, patient will not be telling in history of presenting illness. Once the patient will open up, then you have to talk about discharge characteristics and associated symptoms. and about intimacy history and menstrual and contraceptive history if patient having. And other factors may be sometime everything will be negative, but some factors are there. If patient have used any recent antibiotics or patient is immunocompromised, like say diabetics or foreign body risk factors, maybe tampon, contraceptive device, and now newly in new era. So mostly, sometimes they might add some cases like say gay and lesbian. So please make sure you have to talk about any foreign body risk also. And this is a kind of quite confidential, but you can ask if like so you feel. But this kind of agendas might come in exam. Okay, differential points are there, doctor. You have to think about thrush and bacterial vaginosis on STI. So how you're going to differentiate between that one. In the thrush, doctor, you will be getting mostly thick white discharge, intense itching, and vulvar soreness and little odor. This kind of patient will be more distressed than bacterial vaginosis because this patient don't have any, they having single partner, and most of the time, this kind of patient, they will be coming one hidden agenda. Doctor, I don't believe my husband. He's having some relationship with other wife or other person or something. So here you should not say that your husband, I can understand it came from your husband. No, you should not say, Mrs. Khan, it is not, we can't confirm that it is because of the husband. We have to need to rule it out. Okay. So again, here agenda lies over it, how you are taking care of the privacy. Okay, how you are taking care, that patient is going to blame her partner. Okay, so you should think about that you should not give chance to the SP or examiner to give you some sort of negative approach again, and it might they might twist you around. Okay, bacterial vaginal case, doctor, they will be more open to you. Okay, they will not be having any hidden agenda, but thrush people are always having some agenda in the cases we have seen in the trend, so they will be coming one agenda, as I told you. STI, doctor, mostly young female university student. They will be coming. There will be no elderly patient. Okay, they will be thinking about some discharge plus pelvic pain. You have to ask about bleeding, dysuria, any new partner, or systemic symptoms like say fever, body pain, and other complaint like say back pain kind of stuff. Examination, if it is mentioned, then you can go for you can verbalize this. I will be doing this examination, and even though you are not going to perform over there, investigation, doctor. Always remember, don't say vaginal swab. You have to say high vaginal swab. Examiner categorically they are mentioning about this thing that if you are saying vaginal swab, it means it is incomplete instruction. Okay, incomplete investigation order. So it is a negative marking, and this is we call it pitfall in this kind of cases. We have to say high vaginal swab. Okay, endocervical or not for the STI based on the risk factor. And UPT, we have to check patient or pregnancy test in the women of reproductive age despite whether having patient um, periods or no periods. Okay, management again based on the most likely diagnosis and test results. Sometimes this patient will be coming with a report. It will be showing some sort of some sort of fungus on the report. So you have to treat patient with the candidiasis according to the report. And if patient come with a bacterial vaginosis or trichomonas, you have to treat with metronidazole. If patient come with a bacterial vaginosis, simultaneously you have to treat the trichomonas also. So you can mention as a metronidazole. Appropriate antibiotic for the chlamydia and gonorrhea. Consider partner notification and testing. Sometimes they will be saying that they will be resisting, doctor. I don't want to see. I don't wanted to mention to my partner. Okay, so you have to give chance like same like HIV. So you have to tell the part that patient. You have to explain to the partner. Okay, we need to know and we need to trace out. Okay, and safeguard for fertility. Many times agenda lies over here with infertility cases. Okay, in those cases, we have to recognize and urgently refer for suspected PID with severe pelvic pain. Those kind of patients saying, Doctor, I'm married for 7 years, 10 years, but I'm not getting pregnant. So there is a hidden agenda lies over here. Patient might be suffering from some infection over there. So we have to rule it out and we have to treat that patient. Counseling always it is mandatory, and you have to talk in proper and layman language and advise
Okay.
sexual abstinence and using the barrier methods during the treatment and the need for the partner treatment wherever it is relevant. Safety netting, doctor, always pelvic pain, fever, systemic unwellness, or any other symptom, under any new symptoms. So you can mention over here. Okay, doctor, blood BPH. Okay, agenda again over here. This kind of patient you will be getting. There's a trick. Patient will be age more than 40. Okay, and there will be agenda. Doctor, I'm having a problem in passing urine. Voiding issues are there. Okay, I can't store. I have frequency. I have to go to frequently to the toilet. Urgency, nocturia, and urgency incontinence. Now, doctor, I will be taking one case, one extra point over here in this scenario. In the female, mostly they are testing their patient. Their most commonest and favorite scenario, that elderly patient will be there and she will be saying, Doctor, whenever I'm coughing, I'm getting that, I'm getting leakage of urine. Patient will be distressed. Okay, so you have to deal with that one, and you have to send for the CPT therapy. And examiner want to know that about muscle and pelvic exercises. Okay, so in these BPH cases, doctor, if patient having visible hematuria, dysuria, and fever, low and pain, anything, but sometime patient come with a report, doctor, I don't have any problem, but can you see that my report showing some sort of red blood cells? So this is a cancer pathway. Patient don't have any symptoms, don't have any problem, accidentally found out on the urine that they are having increased red blood cells. Okay, invisible hematuria. Invisible hematuria is a red flag, and you have to refer this patient for cancerous pathway. That is a very rare case and typical case being tested in the exam, and most of the time we miss that scenario. Okay,
Mm.
so because this patient I don't have any problems, I will not be thinking about that thing. Okay, so and acute retention patient sometime it come with you, doctor. I didn't pass my urine since last night. Okay, I'm trying to pass out, but something is holding on, or overflow incontinence. Okay, many patients will be hesitant to tell you about sleep disturbances, quality of life, and embarrassment. Doctor, I feel embarrassed. I have to go to toilet multiple times. So here, those patients will be having history of prostate problem, diabetes, or neurological disease will be there, or some sort of any near back trauma. So you have to ask about any back trauma. Okay, if you are missing that one back trauma, so it will be again it is incomplete asking about past medical history. Okay, drugs mostly if patient is taking some diuretic because of some sort of conditions, anticholinergics, antihistamines, and antidepressant. So here, sometime case might arise, patient having allergic rhinitis, taking antihistamines over the counter many years. Now patient came with this problem. So we have to think about BPH due to antihistamines or antidepressant like schizophrenic drugs are there, some other drugs are there where patient will be having more urination or sorry. Okay, and examination, doctor, here it is very important. Again, here we have to go into general physical examination with abdominal examination, going to palpate the bladder and masses. Here is no upper abdominal examination if there is no involvement of any kidneys. Okay, if there is involvement of lower urinary tract, you are going to examine below the navel. Okay, and you are going to verbalize. I am going to check your external genitalia and digital rectal examination. Urine analysis PSA with counseling you have to say, and if like say you have done digital rectal examination, don't say that I will be doing PSA. Okay, it will be considered incompetent because you already irritated or ignited patient's prostate, so PSA will be irrelevant now. Urea electrolyte, if you think it is a concern, then you can talk about. Otherwise, you should not say that I will be checking your urea creatinine and other things. Okay, you can say full blood count, CRP, or ESR along with random blood sugar if patient don't have any problem. Management, as I say, that watchful waiting, lifestyle modification. Here, examiner want something different than other cases. Here, evening fluid restriction, avoid caffeine and alcohol. Agenda will be there. Patient is taking lot of coffee and alcohol. Okay, and timed voiding. Okay, if patient having moderate to severe, you can start the alpha blocker as per the local guidelines, and you can refer the patient if you are thinking about suspicion of malignancy. That, as I told you, that invisible hematuria, patient found out on the urine test that their red blood cells are there, and patient don't have any other problems. So we have to send this patient to the specialist along with the patient having recurrent retention, gross hematuria, or renal impairment. Counseling, doctor, as again, you have to talk in a layman language and you have to rule about the cancer. But if you don't have proof of cancer, you should not say word cancer. Okay. Safety netting for the detention, visible blood, or if you see systemic wellness, if you're getting fever, low back pain, or leg pains, whatever, so on, a scrotal pain, then you have to come back to us. ED. ED, typical scenarios are there, doctor. I'll be talking a little bit openly now because this is one of the most commonly tested thing in exam. Um, Patient will be having many problems. Okay, so we have to see whether patient having difficulty in achieving or maintaining it. Okay, then we have to think about onset, since how long patient is suffering. Okay, maybe patient got newly married. Okay, but he is not having this kind of feeling before, but now he started getting. So we have to ask about any previous relationship, whether you were getting before or this is the same thing. So we have to go different route, situational or consistent, and morning erections. Psychosexual doctor, you have to think about relationship issues, maybe arranged marriage, not happy, anxiety, mood, stress, and maybe there is a now modern era pornography. Okay, so we have to think, and if patient is taking some medication like say diabetic medication, hypertension, dyslipidemia, or CVD, or neurological disease, or a patient having pelvic surgery or trauma. Okay, here we have to explore all the things. Despite other cases, we have to rule out one or two things. But in ED, always remember you have to go a little bit longer. Okay, you have to ask about all possible things like say diabetes, hypertension, dyslipidemia, atherosclerotic changes, CVD, neurovascular disease, and pelvic surgery or trauma. Doctor, drug and lifestyle. This case come with post-MI depression in exam. Where patient is taking, there will be a dual agenda, combined agenda is there. Patient is taking beta blocker. Okay, agenda lies over whether you are going to stop the beta blocker or you are going to refer this patient to the specialist. So it is a win-win situation. Again, act as per the scenario. If patient is taking SSRI, patient is taking lot of alcohol, patient is smoking, having recreational drugs. So these all the causes of ED. Doctor, what are the red flags where you are going to think about that this patient need urgent referral? If patient having sudden onset with a pelvic pain or deformity, okay, symptoms of hypogonadism, doctor, low libido, low energy, reduced shaving, patient might come with this agenda. Cardiovascular disease symptom like say patient, doctor, I'm getting chest pain, I'm getting exertional dyspnea or claudication. So how are you going to assess, doctor? You are going to consider cardiovascular disease assessment. You are going to order some blood investigation specifically for the diabetic checkup, lipid profile, and testosterone if indicated. You are not going to check other hormones except testosterone. Management, doctor, again, we are going to address patient reversible factors like say lifestyle changes, reduce alcohol, smoking cessation, manage diabetes and blood pressure. If patient having psychological problem, then we are going to think about normalize common nature of ET, consider counseling and psychosocial therapy like say talk therapy. PDE5 inhibitors, doctor, you can recommend to the diabetic patient, okay, or some other patient where you have to explain the demand. Patient sometime we come with, doctor, I want it medication. So you have to consult the patient and you have to ask about risk factors. Then you can give the dose, timing, and need of stimulation and contraindication with nitrates. And always ask, are you using any medication for anything? So there will be hidden agenda lying over there. Patient having stable angina, patient using GTN. If you forget to ask about any drug history, so you will be missing the boat. Then counseling doctor, you have to explain link between ED and cardiovascular risk if patient having, and safety netting for the chest pain on exertion and sudden onset severe pain or deformity in that organ. Yeah, this is again typical case. Rarely tested in the exam, but it comes. Doctor, I have lump on my right side or my left side. Then we have to ask whether it is a painful or painless. Since how long he is facing, did you see in the change in the size? Okay. Then you have to think about systemic symptoms like say, did you got weight loss or breathlessness, back pain? Here, let me tell you, in this case, you have to forget about the age. This can come in the young age also. Here, you should not think this patient is young. Here, we should not ask about weight loss or other cancerous pathway, doctor. Here, we have to ask specifically. And sometime they will be having agenda, doctor. I we don't have baby, but I have noticed that I have lump on my left side or right side, whatever. So we have to ask about trauma, infections, and family history of testicular cancer. Okay, torsion suspicion, doctor. This kind of patient they come with two domains. Okay, one will be a mother coming with a proxy case. It's a young patient. My child is crying because of the pain. I came to take some brufen tablet, pain medicine, or some painkiller. Okay, so we have to ask about whether patient having sudden unilateral pain or bilateral. Okay, mostly it happens in adolescents. Patient will be having nausea, vomiting, previous similar transient episode. This is a medical emergency. Okay, mostly this kind of patient saying, doctor, I was playing the football or I was doing the exercise or night time I wake up, I got the pain in my balls. So red flags, doctor, again, we have to think about acute severe testicular pain. Pain score is more than 7 or 8, whatever, so on, especially in the younger male. Okay. On examination, if like say you say, I'm going to examine the patient. On examination, you have found out that hard, non-tender and irregular testicular mass. If there is any associated symptoms or gynecomastia, these are the red flags, doctor. Examination, doctor. You are going to inspect both sides, size, position, swelling, and erythema, and palpate gently. Don't say I will. You have to verbalize that I will be palpating gently. Okay. In case if you're getting any discomfort, please let me know. Okay. So and torsion features. Management doctor, if you're suspecting torsion, surgical emergency, because this one having window period. If you are missing the board, means you are missing the patient. Okay, immediate same day admission. Do not delay for the ultrasound that I will be doing the ultrasound. Yes, if you're suspecting malignancy, elderly patient or young patient, urgent 2 week cancerous pathway referral, scrotal ultrasound and tumor markers in secondary care they will be doing. I'm going to refer you for that one for the urologist. Benign lump doctor, patient will be coming with epididymal cyst, hydrocele or varicocele, some ultrasound report. Okay, these patients need only referral to routinely to to the specialist, but you have to ask. We have to ask about the history. What is the reasons to of doing this thing, doing this report? So they will be telling you the story. Okay, counseling again. You have to explain in simple words as per the case scenario. Yes, let's talk about Doctor Pediatrics. Um, Doctor Pediatrics case, most not, but 100% it will be coming as a proxy case. There is no examination required, doctor. So mother will be distressed, doctor, my child started going to school and he got fever. He got in touch with her sister who got fever. Then we have to think about patient and age of and duration of the fever, associated symptoms. Feeding and hydration if patient is a small child, okay? If this kind of patient mostly comes with febrile fits, febrile seizures, as we discussed in last yesterday, and background, we have to ask about patient developmental history, okay? Any chronic illness, immunization status, patient child growth, and red flags, doctor. And here, don't forget to ask mother's LMP and mother's age, please. Okay, that is important. Then we have to think about mother's stress level. Okay, there is a pitfall in pediatric cases. That 90% candidates they don't ask mother's LMP and they don't ask mother's stress level. Okay, so you are going to rule out any home violence, child abuse. Okay, that you have to explain that, Mrs. Khan, I am suspecting your child is suffering from the viral fever at the moment. So I need to see him right now, or you can bring him. By the meantime, I'm giving you this paracetamol tablet, 15 milligram per kilo. Okay, and then accordingly you have to give her every 6 hourly. As you're thinking that your child need antibiotic, from the history, I don't think so. There is such thing need of any antibiotic. As you said that her cousin having the influenza. Okay, so I'm suspecting the same way. But for further medication, further treatment, we need to see. Is that okay that if you bring your child right over in clinic? Okay, Mrs. Khan, you have to hydrate your child properly, feed him properly, give him bath. Don't cover him too much, because sometimes mothers they cover a lot because they want to make make the child sweating, so fever will go down. So you have to say there is a chances of hypothermia. Okay, so examination is not required, so I'm not talking about. Here we have to identify the key things. Okay, need urgent assessment if, like say, there is a red flag, like say some febrile seizures fits are there within 24 hours. Second time, patient having drowsiness, not waking up, sleeping, vomiting, not tolerating orally, patient is feeling dizzy and not responding. Very young infants always need to refer, and you have to think about that I wanted to see your child. Always explain in our OSCE style that I'm Mrs. Khan, that you have to seek emergency referral, emergency help if you think that your child is very drowsy, difficulty to wake up, or usually floppy, having breathing difficulty. How are you going to explain breathing difficulty to mother? Labor breathing or noisy, or you feel grunting sound, or you think that your child just running for moving faster. Simple way. Okay, if you think that your child's skin become mottled, blue or cool to extremities, okay, so you think that your child head is hot and your extremities are cold, so you have to bring your child. These are the red flags. Non-balancing rashes appear and persistent vomiting, as I told you earlier, and fever lasting more than 5 days. At the moment, Mrs. Khan, your child doesn't need any antibiotics. Okay. This kind of case come again with a dual agenda. Child with delayed developmental or autism concern. Doctor, my child having some problem. What problem, doctor? Might be speech problem, might be social interaction, might be behavioral motor skills problem. So you have to go one by one. You have to think about developmental domains. Okay, you have to ask about some sort of autism specific features. This is a mandatory point when you are thinking about child delayed development. Okay, you have to ask, Mrs. Khan, do you think that did Mr. Ali, Master Ali having any eye contact? Doctor, he is not having. He is very having limited eye contact. Uh, he can't talk properly. Okay, he is having unusual language use. Okay, or he's shouting, crying, okay, and limited pretend play, okay, rigid routines are there. If someone is moving his or her toy, he or she cry, okay, strong interest and sensitivities, because this kind of cases, doctor, very critical, because here you will be getting marks from only from data gathering and counseling. There is no marks on examination. So this is a win-win situation. These are the typical and difficult cases considered so far. Red flag, doctor, non-blabbing or pointing by 12 months. Okay, these are the cases, doctor. What I red flags I have we have mentioned over here. I'm just going to tell you that non-blabbing or pointing out by 12 months. These are the red flags. This kind of cases came in the exam. No single word by 18 months. No two-word phrases by 24 months. Any loss of skill at any age. In this kind of cases, there is no examination required. But Mrs. Khan, we will be checking your exam. Your in exam purpose, you can say that we will be checking your child growth parameters, especially head circumference, and we will be doing some basic neurological assessment, and we will be checking his hearing and vision. Okay, once we will bring your child over here. So examiner wanted to listen from you. Did you are you able to know that what kind of investigation, what kind of examination do we are going to do on the page on the child? Okay, then management doctor. Many times we have to concern and we have to address patient that mother or parents' eyes. Okay, impact. You have to explain, Mrs. Khan, as you say that you are thinking your child having autism. At the point from your history, I found out he's having some other delays, but we need to further rule further out of need to rule out further. Is it okay if you bring your child over here? Then we will be looking at him. Okay, do not dismiss. Don't say that, Mrs. Khan. No, no, no. You are not. What you are saying, it's not right. No, Mrs. Khan. To rule out further, we need to see him. Simple. And explain the need of comprehensive developmental assessment and refer if, like, say, patient having some speech and language therapy delay, language delay, and you're thinking about possible autism. Mrs. Khan, I will be referring your child to the pediatrician or to the specialist for further rule out. As you're thinking this patient having autism, at the moment from the history, I'm not suspecting anything to rule out further. I'm going to send you early support and counseling. Immunization, doctor, again, very rarely checked, but if it is comes to you, it's very difficult because again, you have to follow immunization protocols, South Asian protocols. I don't know because we're about Sri Lanka, India, and Pakistan. Please follow those protocols. You have to clarify the concern many time, doctor. Agenda lies over here. Doctor, my child having fever. I don't want to give the vaccination. Okay, what is the reason behind? Doctor, my saw that one of my neighbor child, he got fits after that. Okay, he was admitted after the vaccination. Okay, we have to rule out, we have to counsel them about the side effects. Okay, and listen without interrupting. You can say, yes, Mrs. Khan, I can understand. And you have to nod your head. You don't interrupt. Okay, maybe patient having some sort of religious belief that father don't want because he belongs to some strong religion. Okay, he's having some strong religion belief. Maybe they're having some local belief or some taboos are there. Okay, they are thinking, doctor, it might my infertile my child. Like say they many believe that polio vaccination. Okay, many think about COVID vaccination that it may make my child infertile. Okay, many think about ingredient these are not halal, and something they are thinking about mistrust. So we have to clear. We have to check patient understanding and correct the myths gently. Explore information sources. Mrs. Khan, I can understand. May I know from where you heard about that one? I heard from a neighbor. I heard from the Google. Mrs. Khan, first of all, let me tell you, for this kind of situation where your child health is involved and your child future involved, you have to uh, contact health physician who is responsible and who is taking care of this thing, and his or her words are authority. Are you getting me, Mrs. Khan? Because your neighbor might not be the doctor. You should not say your neighbor is telling wrong. No. They say they might file the case against the neighbor. Okay, so you say that you might be thinking your neighbor might not be the doctor, or maybe she had some misunderstanding. Are you getting me, Mrs. Khan? And Mrs. Khan, you're talking about Google. I can understand, but many times we have to when we are talking about Google and the Chat GPT, many times that information is not correct. It's not up to date. Are you getting Mrs. Khan? Okay, we have to up to date information. We will be explaining you. Okay, use clear and non-technical language. Don't blame because if you're going to blame, so examiner will not give you a passing from that station. Okay, you have to emphasize that vaccines are extensively tested for the safety and continually monitored. Serious side effects are very rare, except your child might have some sort of sore throat or some kind of mild fever for one day. For that, we always give paracetamol. Are you getting me, Mrs. Khan? So Mrs. Khan will be happy. But if you say and you're going to blame that patient's neighbor or patient's father or Google or whatever so on, it is we call it judgmental approach. Judgmental approach always having negative impact no matter whatever you do in the case. Share decision. Mrs. Khan, shall we discuss about the about vaccination as you have a lot of concern to talk about? You're going to explain, you have to explain the patient. Address specific vaccines. If they are thinking about Dr. BCG, they are thinking about rotavirus, they might be agenda, doctor, I don't want to give my child influenza. Okay, I don't want to give my child COVID vaccination. Okay, let's talk about doctor. That is about pediatric cases. Let's talk about some sort of yeah. Now, one topic extra I will be talking in pediatric cases: constipation. Okay, so constipation also is a topic we have to think about patients' bulk forming food intake, child behavior, sometimes constipation because of the child abuse. You should, if patient is coming with child coming with um, constipation, we have to ask about. Okay, toilet training, how they are doing the toilet training, forcing, beating the child. So you should, Mrs. Khan, it is not the right way to treat your child while toilet training. If you're treating your child, he might be holding for the days. Then you have to explain in a way. So, doctor, depression assessment, very difficult. Again, but very easy in a way if, like, say, you know that how to tackle the thing. You have to build the rapport. Mr. Ali, I can understand that your situation, but whatever the conversation we are going to talk over here, it will be confidential, and we will make sure that it will be
जल्दी क्यों
it will be confidential. It will be between you and me only. Are you getting me? So you're going to build a rapport. If you are not being building a rapport, so what happen? So expression will not open up till the ninth minute or 10th minute. Do whatever you want. You have to normalize, Mr. Khan. Mr. Ali, I can understand. A lot of people struggling with low mood. It's okay to talk about. Okay. So we are here to help you. Are you getting Mr. Khan? Mr. Khan, I can understand that your situation, what you're passing through. Okay, then you have to explore about patient low mood most of the days, and when you're talking about anhedonia, loss of interest, fatigue, low energy, other symptom, doctor. But many time in our sessions also we have found out um, the candidate they are checking the talking about checklist, but they are not addressing patient. Mr. Khan, may I know that is there any problem we are getting with intimacy? Or if you're getting any problem, is that okay you to talk about? So you have to engage the patient. Psychiatry always about engaging the patient rather than imposing the question or investigating the patient. Okay, so here you have to talk about patient concentration, self-worth, psychomotor thoughts. Okay, Mr. Khan, I can understand you're passing through very difficult situation. Have you ever thought of to self-harm? So here, if you're asking Mr. Khan, do you have anything sort of self-harm? So this is investigative part. Investigative part examiner don't like. Here you can say, Mr. Khan, I know that you are passing through a really tough time, but is there any way, any point you have thought of any self-harm to yourself or to anyone? So they will be telling. This is a proper way, doctor. Impact and context. Okay, many time patient will be having work problem or study issues are there, some sort of relationship issues are there, self-care patient think that he is not worthy. He can't take it. He can't afford it. Okay, then we have to think what was the trigger. Maybe he had a stress at work, job loss, lost his car, lost his house, lost his family members, anyone. Or maybe patient had a long-term illness and postnatal period. Okay, then past history doctor again. Mr. Khan, do you have any past in the past? Do you have any such kind of episodes? Okay, Mr. Khan, about then go for a bipolar and psychosis. Mr. Khan, by any chance, have you tried any kind of substance like say alcohol or drugs? Okay, then risk and safeguarding. Okay, if patient having suicidal thoughts or self-harm, okay, these are the red flags. You have to activate white coat. They call it white code. Okay, any responsibility of dependent and children and caring roles. Okay, and management direction. You have to explain this one about a diagnosis in simple terms. Discuss stepwise approach from step self-help, then talking therapy, then medication. Don't jump to the medication first. Okay, social support. Okay, and safety netting you can talk about. Doctor, suicidal risk assessment. This always come with a depression. This always comes with schizophrenic case. This always comes out of OCD. Here you have to rule it out. So we have to ask about be direct, empathic, and non-judgmental, as earlier I told you. Okay, you can use this line, whatever is displayed on the screen. Okay, you can make your own words. Okay, and key questions, doctor. You can think about like this: have you felt life is not worth living? Or you can ask about, have you had thoughts of ending your life? Then you can think about plan. Okay, and do you have any access to the means? For example, there is a one case. I'm just taking 1 minute for that. Suddenly, while taking the history, patient will say, "Doctor, I saw outside when you was looking at you in your medical treatment room. I saw there is a knife. Will it be helpful to cut the neck?" Patient, you can think there's a patient having suicidal thoughts, or maybe patient having some sort of some killer thoughts are there. So this is for the white coat. Or doctor, I was coming on the way. I thought I saw the rope. Okay, I'm thinking to buy and I will go home and I will try. So how do you think about? I need some medication to relieve my pain while doing this thing. So these are the red flags, doctor. And intent. Past behavior, doctor, protective factors, current state. Patient will be agitated, patient having maybe intoxication and psychosis and severe hopelessness. Doctor, I am thinking that this world is no more. I lost my job. My wife left me. My children don't care me. My friends they left me. I have a lot of debt on me. Social isolation. Okay. So now you're going to formulate how you're going to do action. Low versus high risk. Immediate risk. Don't leave the patient alone. Involve crisis team and emergency. We call it white code. Okay. Consider urgent hospital assessment. Remove or reduce access to means wherever possible. This kind of cases, they might keep something on the table. Okay, which will be unusual while taking that scenario and document and communication, doctor. Anxiety and panic attack, doctor. Panic attack again, palpitation. Your it can go with the chest pain scenarios. Okay, so you have to rule out generalized worsening. Specific phobias. Patient will be having multiple hospital, visits. Everything is normal. Nothing came out. So this kind of patient will be always having intense fear, palpitation, shortness of breath, especially in the middle of the night. Mostly these kind of patients are more young, especially more young female. Okay, dizziness and fear of dying and losing the control. Okay, and we have to think about, ask about onset, frequency, and take a doctor. I last 6 months I visited emergency department 3 times. Why? There is a panic attack or anxiety. Something is there. Something in the relationship also. Many times because these are the agendas are there. We have to think about. Okay, and screen for other condition like say patient having depression, misuse, medical causes, and in the relationship maybe physical abuse or physical trauma. Okay, patient having some sort of problem with family members. Okay, or maybe a small child is there, so he is also having anxiety. There was one case in orientation program. Um, child, 11 years or 12 years old child. He started getting angry all and sudden. We started digging out the history, nothing came out. But lately we have found out both mother and father both working. There are four servants are there. One new servant involved. There was a lady and there was the abuse history. Okay, this kind of patient come to you, so you should not say that I wanted to see your child. Can you bring? No, you have to say, Mrs. Khan, I think your child is in the danger. I wanted to say I am going to I want to inform that relevant authorities. They will be going with you and they will be taking your child out of danger. Okay. But then again, patient is a young patient, then we have to think about other condition. Maybe red flags are there, maybe physical illness, maybe having chest pain or SOB, we have to rule out. Patient impact will be there, sleep disturbance will be there, patient will be losing concentration, work from work and school absent, and relationship issues are there, and avoidance behaviors will be there. Management outline, doctor. First line always talk therapy, then followed by the medication. But now agenda lies over here. Doctor, I went for the talk therapy you sent me last time, didn't work. What's next? Now is the treatment. Now here to talk about SSRI or whatever the medications are there. Okay. Self-help. How he or she can think about self-help. Okay. Breathing control, relaxations, graded exposure for avoidance and sleep hygiene. Remove the screen, dim the light, okay, and take less food, normal clothing, not tight clothing. This kind of thing you can talk about. Medication, doctor. If we are talking about SSRI, always talk about how long it will take to get impact effect and when you have to visit. After 2 weeks, you're going to call the patient. Okay, patient want immediate action. So here, immediate action will not be possible with SSRI. So you have to explain the patient because SSRI explanation, mode of action, and treatment and duration always tested by the exam. No matter if, like say, you have done everything, but you didn't explain to the patient that your how long this SSRI will take, it will be considered incomplete or incompetency in the exam. OCD, doctor, there are two common scenarios tested in OCD. One is doctor. Patient having recurrent intrusive thoughts are there. Okay, images or urge to distressing or unwanted somethings are there. Compulsion, repetitive behaviors or mental acts. Then insight. Okay, we have to, does this patient recognize the thoughts or behavior or excessive or unreasonable patient having idea or not whatever he or she is doing? Checking repeated logs, washing hand properly, okay, checking the stoves, okay, checking the car, checking onto windows, anything is coming up or not. So psychoeducation, you have to explain about OCD and emphasize patient is not getting mad. Many times they will say, doctor, I'm mad. My husband think I'm mad. My wife think I'm mad. Okay, so you have to, yes, you say, even your thoughts are disturbing, but it is not that thinking that you are going to getting mad. So you have to counsel him or her. First line always doctor talk therapy, then SSRI, and avoid reinforcing or compulsion. Okay, and counseling points are there. You can say treatment take time and it is a collaborative. Okay, here in this case, we have to involve the family member. All psychological, psychiatric cases, we have to involve the family members. But this case, we have to exclusively you have to involve the family members. Mrs. Khan, is it okay that if you we involve your husband or Mr. Khan, is it okay that if we involve your wife without taking the consent? You don't should not say that I'm going to involve your husband because this is against the law. You have to say, Mrs. Khan, I'm going to. Is it okay if you allow us? Then she say yes, doctor. This is agenda. And somatization, doctor. Okay. Here you have to be empathic and non-dismissive, Mrs. Ali. No, no, no. You're not. You're wrong. You're doing totally wrong. It's not like this. Okay. You have to validate patient's symptom as a real and distressing, and regardless of the cause. Take detailed history. So how long, how happened, what was the cause, what was the trigger, which makes a better or worse functional impact, daily activities, work or relationship. Okay, and screen for the red flag. Patient might be having weight loss, fever, night sweats. So it means there is some sort of pathological causes also there. Explanation, doctor. Use a biopsychosocial model. So you have to explain that. Body and mind are linked. Persistent stress or past trauma can amplify body sensation and pain. Non-serious disease found does not mean that some symptoms are emergent. Okay, so you have to explain. You have to agree on the plan. You have to take the focus on function, not complete symptom eradication. Okay, after offer CBT and rationalized medications you should avoid and don't over investigate the patient and don't give opiates at the first impression. Insomnia, okay. Insomnia, having a broad picture. It can come from child to elderly patient anytime, anywhere. So we have to ask about sleep pattern, duration and severity and impact on daytime function. Okay, and contributory factor like say patient is taking a lot of coffee, nicotine, alcohol, screen usage, irregular schedule, and naps. Okay, then we have to think about mental health, anxiety, and depression, and so on. And sometimes medical causes are there. Maybe patient having back pain, maybe patient having knee pain, maybe having nocturia, maybe having breathlessness. Okay, OSS symptoms. Okay, so patient will be telling you in HOPI, but again, you have to make sure that you are taking one or two things from there. If like say there's OSS symptoms are there outside the cubicle, there will be a BMI written. If there is no BMI written, you can ask about OSA, but patient will not be OSA. Sleep hygiene advice, doctor, it is always mandatory. You have to explain about regular sleep, wake up timing, even off days also. Okay, wind down routine, no screen close to the bedtime, use bedroom only for the sleep and intimacy, not for work or TV if possible. Remove the TV from the room, remove the iPad, remove your mobile phone from the from the bedroom, avoid caffeine, nicotine, and if patient is using heavy meals close to the bedtime. Limited daytime naps, especially Mrs. Khan, I'm giving you this leaflet for sleep hygiene if you're running short of time. So, doctor, cognitive and behavioral approaches you have to talk, and medication short term you can give, but if in a specific condition, doctor, not all. Okay, and you have to emphasize on that on behavioral strategies rather than the long-term sedatives, doctor. Here, examiner, if you're giving long-term sedatives, it will be considered as incompetent without going through other cognitive and other things. Safety netting, doctor. Okay, one of the most disputed scenarios. Breaking bad news, doctor. Breaking bad news is one of the most discussed topic throughout in our last three groups. So we have to take as a spike way. So first you have to say, Mrs. Khan, whatever we will be talking, it will be confidential. I am switching off my phone. Okay, then you have to make a quiet room, like sitting down, non-physical barriers, minimize interruptions. Okay, then you have to ask perception. What is your understanding, like say, and what has been going on so far? Maybe patient have seen the report. Invitation. Okay, would you like me to go through all information or what? How much you know about this thing? It's based on your doctor practice. Or you just want me to tell about main points first? What do you want? Then patient will be telling you. Then knowledge. Okay? Always give the warning shot. Mrs. Khan, I'm afraid that results are more serious than we had hoped. Take the pause. Look at patient. Patient started crying. Give tissue paper. Patient having some sort of dry throat. Give water. Okay, and then deliver information in small chunks, clear language, not in a one paragraph. No, Mrs. Khan, I can understand the situation is not good and you are suffering from the colorectal cancer. You know about the cancer, this is a cancer of intestine. Okay, as you know that your father also was suffering from this problem. Unfortunately, you are suffering from the same thing. I can understand how tough is the situation and how tough is to digest this news. But good news is that one, it is at not that point, it is a treatable. Okay. For that one, I will be referring you to the specialist. Okay. They will be dealing accordingly. What they will, doctor, my life is ended. I'm going to die anymore. What they will do? This means like a doctor patient is depressed now. Here you can say, Mrs. Khan, don't lose hope. There are many treatments are there. So we call it we call it chemotherapy. They will be treating with injections. And one is a radiotherapy. They will be giving you some sort of radiations. Okay. This is based on the specialist decision, what they're deciding as per your condition and as per your health. Are you getting me, Mrs. Khan? Okay. Then emotions and empathy, doctor, is important. Respond to the emotion. Yeah, Mrs. Khan, you seem shocked and upset. I can understand the situation. I'm so sorry that you are going through this, but at the moment, and take silence, as I told you, offer a tissue paper, whatever, so on, and strategy you have to make. If it is needed further test, you talk about. If there is some other meeting to oncology team or referral, you have to talk about and check what they want to tell the family. Mrs. Khan, I can understand the situation is very tough for you. Uh, with whom you want to share this news? Doctor, my husband has been having already bypass recently. I can't share this news to my husband. My son is very small. Is it okay that if you are sharing this news with my sister? Khan, I can understand your situation. So we'll be sharing as per your um, consent. I'll be sharing with your sister. Okay, here you should not say that I'm going to share. You have to take patient consent. Summarize key points and offer written information. Khan, this is written information about this thing. Is then there is a phone number of my personal phone number and clinical phone number is attached.